Hepatitis C is an infection of the liver, and it's a chronic infection that leads to chronic liver disease. And as a result of chronic infection, it can lead to cirrhosis, liver cancer, and liver failure. Now is a very exciting time because it is one of the conditions that we can treat and cure of the chronic infection. The advances in hepatitis C lately has been dramatic. We have seen a 180 turnaround in terms of the treatment that's available. In the past, hepatitis C treatment has been prolonged and associated with significant side effects. These treatments are now one tablet once a day with excellent success up to 98% of the time, and with a very short duration of treatment as low as 8 weeks, and really have no side effects. There's a lot of myths out there about the cost of these medications. We as a nation are extremely lucky to be able to access these drugs on the pharmaceutical benefit scheme. What is known to be S100 in the past, where you have to have had the ability to prescribe hepatitis C once you've done a course, is no longer required for hepatitis C infection. Nonetheless, if people feel inexperienced about prescribing these drugs, they just have to be working with a specialist, but no specific course is required. To test for chronic hepatitis C infection, the first thing that anyone should consider is doing a hepatitis C antibody. This will allow for the clinician to decide whether the patient has ever come across the infection in the past. Thereafter, if they're antibody positive, we will recommend for the clinician to do a hepatitis C RNA testing, which will tell us the genotype of the virus, and if necessary, do a viral load as well at the same time. Hepatitis C is a infection of the liver that really has no symptoms until the situation is too late. It may manifest initially as liver function derangement, so I urge all GPs in patients where they have liver function derangement to consider doing a hepatitis C screen in those patients. In particular, anyone whom previously have had injection of intravenous drugs, even past or present, through to people whom had blood transfusions before the 1990s, people whom had tattoos which were especially done in not a professional manner, as well as people who were born overseas in endemic areas, to families whom have hepatitis C infection, all may carry the virus without any symptoms, especially in the early stage. So in those patients, I urge all GPs to think about that as a potential cause of the liver function derangement and screen everybody if possible. In particular, hepatitis C in the low-risk population, I mean those people that have minimal scarring of the liver without significant comorbidities or drug-drug interactions, can be easily treated by GPs in the community. Some GPs which are able to treat these patients with experience can treat without any specialist involvement. However, for the less experienced GPs, they can always work with a specialist initially to get that experience, and then thereafter they can prescribe independently. In the past, mental health disorders has been a major barrier to hepatitis C therapy because of the use of interferon treatments. We knew that interferon unfortunately worsened depression during hepatitis C treatment. Nowadays, with the interferon-free option, which means that now tablet therapies for hepatitis C no longer use interferon, this will be ideal for a patient with mental health disorders. Provided there are no drug-drug interactions with these medications, which in general there isn't, we would advocate that anybody with mental health disorders should be commenced on therapy for hepatitis C infection without significant complications or side effects. So hepatitis C infection in prison is a major problem. We know that the hepatitis C antibody level in anybody currently in the correctional services is as high as 40 to 50% at times. Given that, hepatitis C therapy in the prison services is so critical, not only to eradicate hepatitis C overall, but decrease the viral pool, which prevents transmission of hepatitis C to other individuals in the correctional service. For people actively using drugs, this is not a barrier to not to start therapy. In fact, we encourage anyone past or present injecting users to use these new DAA treatment, which will decrease the viral pool and decrease the likelihood of transmission of the virus to other individuals as well. For that reason, we would actively encourage our GP colleagues to prescribe these agents for patients currently injecting drugs, but consider regular follow-up to ensure that firstly, they're able to take these medications in a compliant fashion, and secondly, to make sure there are no other ongoing risk of reinfection with repeat hepatitis C DNA, RNA PCRs as well. It is important that GPs recognise that pathway or mode of transmission to inform the patient who they know has already got hepatitis C infection, to inform those they share needles with that they potentially could be infected with the same virus as well. The importance is not only to make a diagnosis of hepatitis C infection in those patients, but more importantly, to recognise that there are treatment available now to treat everybody within their network of potentially infected hepatitis C individuals to be cured of the infection. So in summary, hepatitis C now has become a problem which can be eradicated. We've got very good treatments available at this point in time that can ensure excellent outcomes for all our patients with chronic hepatitis C infection, a treatment that has no real side effects, and treatment duration that are as short as 8 weeks. For that reason, we encourage all of our colleagues whom are in the general community, our general practitioners, drug and alcohol specialists, mental health workers and correctional services to think about hepatitis C as a problem that can be cured, and to consider that in every patient they come across that may be at risk of hepatitis C infection, to test their hepatitis C antibody and commence therapy as soon as possible.